you've been working in anti-infectives and vaccines for most of your career at Merck, which actually among the pharma companies, my experience always was that it's the most science-driven of the companies and really work from principles of science, unlike some other companies that were more business-focused. Tell us about why you chose this path in the first place and actually how it led you into the area of global health.
Thanks, David. I chose the path first focusing on studying pharmacy, and that was influenced by two childhood experiences, one being losing 3 siblings to different diseases, one pneumonia as an infant secondary to measles before a vaccine was available, and then 2 sisters who died of a rare genetic disease that we were unaware, my parents were unaware was in the family, and there was no treatment available then. And even today, there really isn't an effective treatment for this rare enzyme disorder. So they lived, I guess, after diagnosis for 6 or 7 years, and I was age in between the 2 of them. And so I grew up with sickness and eventual death around me. Well, at the same time, my father was a pharmacist and owned a retail pharmacy, and I saw the tremendous impact that medications and vaccines can have. And I kept, trying to find a way to bridge the two, and unfortunately, there just wasn't any way to use any available medications to help them. But out of those 2 experiences came a desire to have an impact in the field of pharmacy. And I started out intending to follow in my father's footsteps and do that in a retail pharmacy setting. But I had a great opportunity one summer in pharmacy school to do an internship at Merck. And the first couple of weeks I spent in the research laboratories, and this was in the early 80s, and it took me about a week to realize that if I wanted to make a broad impact through pharmaceuticals, that the best way to do it was a science-driven company like Merck, who had the expertise, had the passion, had the resources, and was willing to invest to address unmet medical needs. And it was an exciting time in the early 80s, even though financially Merck was doing terrible. But there was tremendous excitement in the research labs for vaccines like the hepatitis B vaccine they were about to launch, other new chronic medications, and anti-infectives as well. And so I chose to join Merck, and then I had the opportunity over time to work on vaccines as well as HIV therapies and other anti-infectives. And I found that to be the most rewarding part of my 26-year career. And I would say vaccines even more so than anti-infectives. I mean, it was great with that, hospital-acquired infection. We had an antibiotic that could cure that patient, get him out of the hospital in a few days. Well, you didn't necessarily get the same level of satisfaction with HIV therapies, although in the last couple of years it really is becoming a chronic disease, and you do get much more satisfaction of having a very positive impact on the quality of life. But to me, vaccines were the quintessential approach to addressing disease by preventing it from ever happening in the first place. I had a portfolio of 14 vaccines, including many childhood vaccines like MMR, measles, mumps, and rubella. Had the privilege to introduce HPV vaccine, Gardasil, to address and prevent cervical cancer, and many other vaccines. And I also had the opportunity to become involved in global health. Because it was really not obvious to me early in my career the access issues that existed throughout the world. It doesn't become as well known for chronic therapies like hypertension. You don't hear a lot of complaints that countries can't get the same antihypertensives. I'm sure they'd like to, but where you really see it come to the forefront is infectious disease, where you may have hundreds of thousands, or in the case of HIV, malaria, millions or hundreds of millions affected by these diseases, and TB as well. And you ask yourself the question, if there is effective approaches available, why can't we find a way to create access? So it's terrific that we've done that for millions of patients with HIV. We have to do a lot more. But really the only way to eradicate a disease, as we saw certainly with smallpox, and hopefully we'll see with polio, is an effective vaccine. And so I became committed to that area, and that led me to join the board of IAVI so that I can continue to help make a difference in that area.
Great. I think one of the striking developments in the area of malaria, I remember the first UN report that was looking at mortality, and when people were expecting to see mortality in the millions, and we're now at the point where mortality is in the high 100,000s, 800,000, 900,000. principally because of the use of bed nets and better drug therapies. And yet we continue to look for a vaccine. Tell us, John, why a vaccine is needed, given the important other efforts that are taking place. And if you could extend that into the area of HIV, where we have certainly good chronic therapies, why do we still need a vaccine?
Thank you, David. Yes, it's true that according to the report of World Health Organization of last year, deaths due to malaria has declined tremendously from 1 million in a year to around 0.8 million in a year. And this has been claimed to be due to the use of bed nets and also early diagnosis and treatment, and also the indoor residue spraying. That's fantastic. But still, malaria is a great problem in our communities. As we are saying, it has declined from 1 million to 0.8 million. So still is a big chunk, is a big problem. It's a big problem. And we think that, as we heard from Maggie here, that she believes in the vaccine that they are the ones which are bringing into elimination and even eradication. Like we have seen the successful story about the smallpox, and now the polio has been eliminated in some countries and is towards eradication. And we think that by having a malaria vaccine, it will complement the existing tools and probably go into elimination in some parts and probably eradication later on. So with the first generation vaccine, probably will aim at complementing and reducing the burden. Probably if the vaccine is 50% efficacious, then it can reduce maybe by 50% if it's used with the other tools. Maybe the deaths will go down to 0.4 million. But we are not sure yet. But that is our aim, and probably later on, when we get a second generation vaccine, it may go down to elimination and eradication. And this is an important thing for the economic growth of the poor countries, and also with the global investment, that even the investors who are coming from developed countries where they are less immune to malaria, they can accept to go and invest in a malaria endemic country like ours if there is a vaccine whereby they are quite confident that if their children are going to live there maybe for a short time, like 3 months, they can get a vaccine that is going to prevent them from malaria, and the economy of the country will increase. So we also see that there has been a great support through global funds to fight HIV, AIDS, and malaria, and also tuberculosis, and also through PEPFAR, that we can see that there has been a great supply of, or large supply of antiretroviral drugs. And these antiretroviral drugs have been used tremendously, and I was chatting with the other people who are present here. I don't know their names exactly, that, you know, in Tanzania, a lot of people have used the antiretroviral drugs, and now those home-based care centers, they have now been closed because most of the people now have improved and they can move here and there. And again, the use of condoms have been promoted very highly. So those who cannot abstain, they can use condoms. So the health education, information education, and communication is very high. And the most important thing is that there is a high-level advocacy. Political leaders in the country, including the president in the country, is having a great campaign, is leading a campaign. One of Malaria No More, with the former ambassador of Tanzania, Mark Green, and also the other one is having with the HIV AIDS. He even tested himself to show a good example in the country, and then other people, they volunteered, such that when HIV was measured, it was shown that the previous prevalence has now gone down compared to the current prevalence. So there has been a great change also in malaria, in HIV/AIDS.
Great, thank you. So, Michael, I'd like to turn a little bit to the value proposition for vaccines. Margie mentioned how impactful vaccines can be. Let's give it a little bit of an economic focus. The U.S. spends today about $4 billion on promoting treatment in the developing world, which is about a quarter of the global spend for the developing world. where does the investment in new prevention technologies fit, and how should we think about that as a government? And I want, in addition to the economic argument, tell us a little bit about the ethical argument for actually making that prevention investment.
Well, I think, when you're talking about ARV treatments, they are an expensive health intervention. I think they were a necessary health intervention to forestall a crisis. They played a very important role in reducing stigma, that this was not a death sentence. They played a very important role in promoting testing. I mean, what's the psychological motivation of giving testing in the absence of treatment? So it was an expensive, necessary emergency intervention. But of course, we've discovered that having helped stabilize societies, across Africa in particular, that we're not going to treat our way out of this crisis. You can't get there from here. The goal of universal treatment is getting further away rather than closer. We've reduced the total numbers of deaths each year from AIDS, but the infection is increasing much faster than we can put new people on treatment. And so this is creating a long-term problem that's not just unsustainable for international donors, but unsustainable for the countries themselves. It's just a massive burden of chronic disease with people on treatment the rest of their lives. A bunch of things that were taken as emergency measures, you have to then ask the question, well, what follows an emergency? How do you make it a sustainable circumstance? And clearly you have to have focus on prevention. And there's a variety of ways to approach the prevention issue. It could be mother-to-child transmission, which is something that's almost completely preventable that we could get a handle on. In the initial days, it was blood supplies, and we spent a lot of time and effort on that, on those kind of issues. There are behavioral aspects, right, for multiple concurrent partners, or condom usage, and a lot of other things that are important. But whenever you're entering the human equation into these epidemiological problems, it's a challenge. It's difficult. So ultimately, we need vaccines for it to be sustainable for us and for these countries themselves, so they can turn to other forms of growth and confront other forms of disease. I mean, you do have chronic disease problems in Africa, heart disease and diabetes and cancer and a lot of other things that right now many societies are confronting these crises of AIDS and malaria that they can return, with a vaccine, might be able to return to a more normal health system to approach a lot of these problems. We're now reaching a circumstance where we're not going to, I wish we had a lot more resources to spend in these kind of, debt-constrained Western economies, and we don't. And so we're going to have to get the very best value for our money in going forward. One of those, in my view, is Gavi. There are a couple of stages here. One of them is just the application of existing vaccines to save millions of lives, particularly from diarrhea and pneumonia, and routine vaccines that we could put into universal distribution. And then the next step really is on the vaccine side, which you hope 10, 15 years, in that type of time frame, you can make a fundamental change in that calculus.
So